Migraine is estimated to affect up to 40 million Americans. Over a lifetime, about 25 to 30% of women will experience migraine and about 9% of men. So it's just extremely common. I think it's ideally treated in primary care because migraine is a chronic illness, and nobody has a better view of the longitudinal changes than a doctor who's seen someone over a long period of time.
Research has really changed our perception of migraine, and there are different theories about what causes migraine, how it's evolved. In the beginning, people thought of migraine as this excuse to get out of work. I have a headache, I need to go lie down.
It was common to think of migraine as a condition that was either caused by or heavily influenced by psychological or psychiatric factors. With the advent of effective biological treatments for migraine, people were forced to re-examine their ideas about that.
At one point, migraine was thought to be secondary to blood vessels dilating or becoming bigger.
Expansion of blood vessels produced the headache, and then treatments that produced some constriction of blood vessels treated the disorder. It turns out that's too simplistic. Blood vessels may be involved. Some of the medications that are effective for treating migraine attacks do have effects on blood vessels, but there are many other treatments and medications that have no apparent effect on blood vessels that are effective for migraine.
In recent years, we've honed in on this neuroinflammation and this pathway in which neurons are activated and triggered and cascade into the central areas of the brain.
Migraine exists along a spectrum of severity. There are people who have only a couple of attacks a year, or maybe even only a couple of attacks during their lifetime. And then there are people who have daily or near daily headaches. The vast majority of people with migraine are somewhere in the middle. Migraine is often misdiagnosed. I think it's because the characteristic features of migraine are not uniformly present. So although the name migraine comes from the term hemicrania, meaning one side of the head, it doesn't have to be. And so people for whom headache is on both sides of the head or generalized might be inaccurately diagnosed as having tension-type headache. I often say that with tension-type headache, the headache is the problem. With migraine, it's the headache, but also it's often the other accompanying features. People often have nausea, vomiting, sensitivity to light or noise. Those are things that are absent in people who have tension-type headache.
Individuals can experience other symptoms, and that can be difficulty speaking. A visual symptom where there's shimmering light that moves across their visual field. People can have numbness and tingling on one side of their body.
Then too, I think migraine is often thought of as a disorder that principally affects women. That's true, but because it's so common, it affects a lot of men too. So I think that men with the disorder are at risk of being diagnosed as having something else, and then they may miss out on treatment. There's a misunderstanding when it comes to treatment. There's an idea perhaps that there's one best treatment for everybody. And in fact, it's more complicated than that. It's a matter of balancing not only the benefits of a treatment with the side effects of a treatment, but also thinking about the potential long-term complications. I often tell people that treatment is a work in progress. There are a number of treatments that are commonly used to treat individual attacks of headache. Probably the biggest category with which everybody is familiar are the simple analgesics. I would include acetaminophen and anti-inflammatory medications in that category. It can also be helpful to use combinations of medications. A common scenario is someone for whom over-the-counter medications like anti-inflammatory medications work well most of the time, but sometimes they're sick to their stomach and they're not able to keep them down. There, all you might need to do is add an anti-nausea medication. One turning point in the field of headache medicine was the development of the triptans in the late 1980s and early 1990s. These were medications that were specifically developed to treat individual attacks of migraine. Triptans are widely available, and those, I would say, are the mainstay of treatment for most people. Sometimes it is necessary to experiment with different triptans, different doses, different formulations to find the one that works for someone. I think they're superior to sedative medications, the barbiturate combination medications, for example, that used to be very commonly used to treat headaches. Triptans, while they're very well tolerated by the majority of people, certainly can have side effects. The most common thing I hear is they might have some tightness in their throat, their chest, or their shoulders. We've got a number of newer treatments that can be used to treat individual headaches. One category, often referred to as the G-PANTs, are the small molecule oral medications that oppose the actions of calcitonin gene-related peptide, or CGRP. They're generally very well tolerated, and they're more effective than placebo for treating an individual attack of headache. And then the ditans. These are medications that attempt to improve on the side effect profile of triptans. The ditans may be a little bit less likely to produce worrisome vasoconstriction. They also can produce sedation, so the trade-offs are important to consider.
If someone is taking the acute therapy more than 2 to 3 days a week, then you might want to think about a preventive at that point.
We have a number of medications that can be used to cut down on the number of headache attacks that people have. We hope to achieve at least a reduction of 50% in the number of attacks that people are having. And sometimes, in addition to having fewer attacks, people will also have less severe attacks.
They span from different classes of medications: blood pressure medications, anti-seizure medications, medications for depression.
For example, if someone has underlying high blood pressure, then it makes all the sense in the world to try to use a medication that might be helpful for both conditions. The newest medications that we have are antibodies to calcitonin gene-related peptide, which can be injected and help cut down on the number of migraine attacks that people have. They certainly, at least in the clinical trials, appear to be well tolerated. Obviously, we're gaining more experience with potential adverse effects and side effects, but I would encourage primary care doctors to at least investigate the possibility of using newer medications. They don't work for everybody. Nothing we have does, and that's not a cause for pessimism. That's the way it is with any chronic multifactorial illness. We're very used to making this distinction that, frankly, in a lot of cases is arbitrary between these are acute medications and these are preventive medications. But in fact, there are categories of medication that can work in both ways. Anti-inflammatory medications, for example, aspirin, can be used to treat an individual attack, and there's evidence from randomized controlled trials that aspirin can be helpful in cutting down on the number of attacks. The same is true for the G-PANTs. We can make educated decisions about what is very likely to work for someone, but there's no substitute for trying a medication to figure out whether it's something that is effective for the person and whether the benefits they get outweigh any drawbacks in terms of side effects or inconvenience or discomfort of using the medication.
Unfortunately, many of the medications that are used for migraine cannot be used during pregnancy, but there are options for individuals who are pregnant in order to keep the baby safe and also help with lowering distress and disability during that time period.
Migraine is a condition that has many genetic influences. This genetic tendency interacts with environmental triggers, both internal and external triggers, some of which are under a person's control, others of which, like hormonal fluctuations, might not be. There is really not a one-size-fits-all lifestyle prescription, and sometimes well-meaning lifestyle prescriptions, I think, go way beyond what's evidence-based or likely to be true for an individual person, and can even make them feel like they're responsible for their attacks. It's not always the case that you have a headache because you did something wrong. Sometimes you have a headache because just your internal threshold for having headaches is low, and sometimes it's breached. I am concerned about effective treatment for migraine, especially newer treatments. They have priced effective treatment out of the reach of the very patients who would most benefit from it. Even patients who have insurance often are unable to get medications. I think that Systemic changes are needed. This is a problem that goes far beyond the headache field. All of this needs attention, and it needs attention at a congressional level. I'm excited about where we are in terms of understanding migraine and by the momentum that I see. People who are suffering and are disabled by migraine deserve to feel better.